Good morning, I'm Dr. Bancha Chernchujit from Thammasat University, Thailand. Thank you, Philippines Orthopedic Association. Thanks, Possum and MyTech for the invitation. My topic today is Hybrid Suture Bridge technique using Dynacord in massive rotator cuff repair. This video demonstration shows the massive rotator cuff tear in cadaver. What is massive rotator cuff tear? There are many definitions about the massive rotator cuff tear. For example, tear size more than 5 centimeters or complete detachment more than 2 tendons. The latest definition from Delphi consensus study published in journal Shoulder and Bone 2020 define massive rotator cuff tear as retraction of tendons to the glenoid rim in either coronal or axial plane with more than 67% of greater tuberosity exposed, measured in sagittal plane. Arthroscopic images demonstrate a massive rotator cuff tear showing more than 67% of greater tuberosity exposure with little remaining tendinous attachment. MRI images showing a retraction of the rotator cuff medial to the glenoid rim. The massive rotator cuff tear can be classified into massive irreparable and massive reparable. The scope of my talk today is massive reparable cuff tear, ASI more than 6 mm, Couturier fatty infiltration 2 or 3, Pate cuff retraction 2 or 3. For me, the cuff retraction is less important than cuff quality. The physical examination is critical. The postural superior cuff tear, supra and infra, which is more common and easier to treat. But the anterior superior cuff tear, supra and subscap, is less common but more complicated and has worse prognosis. The results of massive rotator cuff repair are variable and not reliable. The latest systematic review from ESCA 2020 includes 1,400 patients at mean follow-up of 3 years. They found that the failure rate is around 35%. The massive rotator cuff repair is challenging. Try your best to cover the defect because it's proof that the patient will have better result comparing to debridement alone. The concept of my cuff repair is number 1, tension-free repair, number 2, maximum footprint coverage, and number 3, minimum soft tissue or cuff trauma. How to get the tension-free repair? We must always start with soft tissue release. Do not repair the cuff without release because the tension will be too much and finally it will be torn. This is example of my supraspinatus release. I did subcommion release, rotator interval release, coracohumeral ligament release, and supraglenoid release until I make sure that the cuff is freely mobilized and tension-free before the repair. The video demonstrates how I do the subscapularis release. I did triple release, superior part, anterior part, and posterior part to the subscapularis tendon. Video demonstrates the massive subscapularis tear. I did triple release. The superior release from the rotator interval don't resect the comma tissues. The anterior release from the coracohumeral ligament and expose the coracoid neck and base and conjoint tendons. And the posterior release the MGHL, IGHL, and anterior capsule. The interval slide was proposed many years ago, but less popular now because I think it's too invasive and higher chance of the retaliate. I prefer bedside position for my cuff repair because I can access around the shoulder and the shoulder is freely mobilized. These are the portals for my massive rotator cuff repair. I have allowed 5 portals as shown. Another problem that can be the cause of the rotator cuff tear is the suture loosening. This is a very good article published in Arthroscopy 2010. They found that the suture loosening and contact pressure drop over time. All repair constructs had decreased footprint contact pressure and contact area after 160 minutes, around 3 hours. However, the suture bridge with middle knot tying had highest contact pressure initially and persists better over time. The biomechanical study from Arthroscopy 2011, they found that the suture bridge rotator cuff repair construct have some loosening around 1 mm after 1000 cyclic loadings. The biomechanical study published in 2017 comparing suture versus tape concluded that rotator cuff repair using tape had greater footprint contact pressure and ultimate failure load comparing to the suture. The Dynacord suture may be the solution for this loosening over time problem. At the beginning, I don't believe that, so I did my own experiment. I put the Dynacord and typical suture from other company into the saline for 6 hours later. You can see that on the left side, the Dynacord is bigger, significantly comparing to the right. This comparative study between Dynacord and typical suture for another company found that the Dynacord was shown to be self-tensioning, providing continuous compression for at least 12 weeks, while the typical suture from another company was shown to be loose 52% of tension after 24 hours. Another cause of failure is the cuff strangulation at the middle knot tying. Too many holes in the cuff and middle knot tying can be the causes of vascular strangulation and resulting in type 2 tear as shown in the video. From this study, they found that the gap between the hole should not be too close. They recommend 7 to 8 millimeters between the hole to prevent vascular and soft tissue strangulation resulting in type 2 tear. I used knotless suture bridge for a while, but I need to stop because it looked nice from outside, but when we put the scope into the joint, there's a gap underneath the knotless area, but at the knot tying area, there's no gap. So that's why I changed to the new hybrid technique. The name is 1-2-3-3-2-1 Hybrid Suture Bridge technique. I use 2 triple loaded anchors, so there are totally 12 sutures, but I make only 6 holes in the rotator cuff, less tissue trauma. So the numbers of suture in each hole will be 1, 2, 3, 3, 2, 1 respectively. The gap between the hole is 7 to 8 millimeters. I prefer triple loaded anchor, but the Helix Advanced BR with Dynacord in Thailand is double loaded. This is a trick to change the double loaded to be triple loaded anchor. This video demonstrates how to perform the 1-2-3-3-2-1 suture bridge technique. After knot tying, each hole will have 2 sutures. Then 6x6 suture bridge technique to the lateral row. We can get the nice footprint coverage with uniform suture distribution. This is a trick to perform the knot tying. We use the posterior post for the left side and anterior post for the right side. Finally, each hole will have 2 sutures and ready to perform the lateral row suture bridge technique in uniform way. Then we can spread the suture to every area of the footprint to get maximum footprint coverage. 6x6 suture bridge technique. 64 years already, she has right shoulder pain for months after falling. Examination revealed drop test positive, drop arm positive, and belly press positive. MRI show massive supraspinatus and subscapularis tear. Intra, we found big size rotator cuff tear after complete soft tissue release from the coracoid process. Then put the anchor sutures at the middle row. I put 3 triple anchor at the middle row, and then pass the suture into the cuff. The gap between the suture is about 8 millimeters, and this is a final construct, stable fixation, good compression of the footprint coverage. 2 years after the surgery, the patient had good shoulder function and good healing of the rotator cuff from MRI. 17 years old lady, she has right shoulder pain and weakness for 6 months. MRI show massive rotator cuff tear. This patient had poor cuff quality, so I used the bicep to augment the superior defect. So we put the anchor and then perform the side-to-side cuff repair together with the bicep, and then doing the suture bridge to cover the defect. You can see the biceps covering the superior defect. Like that, okay? 2 years after the surgery, the patient had good shoulder function and good healing of the rotator cuff. 68 years old male has right shoulder pain after trauma for 3 months, severe shoulder pain and weakness, drop arm positive, external rotation stress test and lag side positive, belly press positive. MRI show massive 3 tendons tear with bicep subluxation. Intra, we found big size cuff tear. The supraspinatus and subscapularis retract to the glenoid level. So we do extensive release. Release the rotator cuff from the glenoid, release it from the coracoid process, release the capsule, release the rotator interval before starting to do the repair. Make sure that the cuff is freely movable before starting the repair. I put 2 anchors for the subscapularis and put 4 anchors for the supraspinatus. After adequate release, we put the anchor, reduce the apex of the L shape, reduce the supraspinatus to the infraspinatus. So this is a key stitch. We need to tie the knot, reduce the supra to the infraspinatus. This is like apex reduction. These are the final repair of the supraspinatus and the subscapularis tendon using hybrid suture bridge technique. The concept of massive rotator cuff repair includes tension-free cuff repair, maximum footprint coverage, less cuff strangulation and trauma. Using the new Dynacord combined with hybrid suture bridge technique may reduce the suture loosening over time, and the swelling thicker Dynacord act like suture tape, which may have better contact area and healing, as shown in the right picture. Thank you, Possum and Philippine Orthopedic Association again. See you again in APCAS meeting Pattaya next year, Thailand. Bye bye. Stay safe.